The more patients you treat, the more reimbursements you get, so on and so forth. I think one of the big aspects of transformation, which is what everybody's talking about, digital transformation, is moving from volume to value. And that's it's actually consistent with what the rest of the healthcare industry is doing. We're not having things like value-based care, which is we're not paying for activity, we're paying for the outcomes of what you're doing. If you don't have good outcomes, we're not paying you, or we're paying you less, right? So the value-based thing has had a struggle trying to be adopted, but it's now becoming very much more prominent because we have data now. We can actually say, oh, your outcomes are better than the guy down the street, things like that. So you can leverage process discovery, deep analytics, and you can identify things like high-risk populations. You can use AI to identify other factors that predict different risks and stuff.
Welcome to Podcast Wise, Perspectives, Cybersecurity, and AI. Look across any modern healthcare enterprise right now, and you'll find an explosion of AI point solutions. But as these tools multiply, so does a quiet compounding risk: digital clutter, model drift, and an overwhelming accumulation of technical debt. True digital maturity isn't about deploying more algorithms. It's about agentic orchestration, moving toward a unified governance layer that can securely manage an entire fleet of AI agents. The question for leadership is no longer if you should adopt AI, but how you balance that rapid innovation with rigid compliance and zero-trust data integrity. Joining us today is physician-turned-technologist Dr. Chow. We dissect the friction-free future of ambient clinical intelligence, the CFO's argument for proactive data modeling, and the critical data architecture framework CEOs must build over the next 24 months to gain a true competitive advantage. Grab your notebook. Let's head into the boardroom. And don't forget to like, share, and subscribe.
Hey, Dr. Chow, how are you?
Good. How you doing, Guten?
I'm good. Likewise. So I'm going to jump right in. So looking back at the early days of health tech, what is one futuristic prediction you made 10 years ago that surprised you that is actually like a mundane reality today?
Yeah, I think probably the one thing that stuck out in my mind was even 10 years ago, I was thinking about AI. But looking at it from 10 years ago, who would have thought how fast AI would have developed?
Mhm.
It is exponential. And today we're seeing AI get better and better almost week by week. And that was what was kind of, looking back, looking at this from way back, I don't think I would have predicted that. In fact, in that time, people were predicting that AI will really be adopted in 20, 30, 40 years. And now we're talking about, artificial general intelligence coming in the next year or two, and people are debating that. But that advance in technology is almost faster than the advent of the internet. That's very shocking.
Yeah.
And I've gone through an entire spectrum at my age, gone through an entire spectrum of changes from, when I was a child, we were watching black and white TV, and
Oh, yeah.
today we're flying past the moon, and doing all kinds of strange things. But I think it's a very exciting time for healthcare, but it's also a very, I would say, an uncertain and risky time. The nature of healthcare is changing. The nature of work models is changing. And
Mhm.
so it's a very exciting time. And I talked to a lot of sort of young clinicians, nurses, physicians, who are very worried about the traditional model of healthcare and if that will be still viable. We still train physicians pretty much the same way to be autonomous, to be basically responsible for everything. And today we're switching towards teams that include AI agents. We're switching towards a diffuse responsibility and authority and things like that. It's a different model, actually, basically fundamentally a different model.
Okay.
Yeah.
Now, how do you define the threshold between useful innovation and digital clutter in a modern healthcare system?
I think the threshold is defined by cognitive friction. So I've been leading innovation of the big systems traditionally. Usually, when you see innovation in healthcare, it's more screens, more
Mm.
alerts, more data entry, and of
Yeah.
course, physicians just hate that. Nurses hate that. So digital clutter happens when technology demands more from the clinician than it gives back. And I think
Mm.
because of that, especially the experience with the electronic health records, it's left a bad taste in a lot of clinicians' mouth. In fact, a lot of clinicians retired early because of that. But true innovation, I think, in the future and going forward is ambient and invisible. And I think it uses process discovery to figure out what workflows are broken, and it injects conversational AI or automated documentation directly into the existing care stream. So it's essentially it becomes invisible, like an invisible assistant.
Mm,
So it doesn't become clutter. It sort of pops up when you need it, and it knows when you need it. And I
okay.
think that's going to be the future. And in fact, the latest hot thing right now is ambient clinical intelligence or auto scribing in patient exam rooms.
Yeah.
Physicians love that. I think Kaiser has had 24,000 physicians try it out and they all love it. Not all, but many of them love it. And it's where you walk in and then the AI actually keeps track of what's going on through a mic and then generates that structured report when you leave. So very, very nice for the physician.
Yeah. So they got great feedback from the patients.
Patient too. I mean, the patient, they're now getting 100% attention from the physician.
Mhm.
What they used to get, and a lot of them kind of wondered about it, is the physician would turn to them, then would turn to us a computer, and this kind of swivel chair back and forth would happen about 50% of the time. You're kind of the patient's talking to the physician, kind of looking over their shoulder, and the physician talk to them, then turn back to the computer,
Like
trying to
this.
find something for them. And that we're going back towards a traditional model where the physician puts their 100% attention on the patient and the patient feels like the physician is paying attention. Yeah.
Yeah, that's good. That's a good ROI on the auto scribing.
Yeah.
So, from a C suite perspective, what is the single biggest risk of underinvesting in AI driven clinical decision support right now?
Right. I think traditionally, when you look at clinical decision support, if you talk to the quality people, the biggest problem with the practice of medicine is variance, institutional variance. Usually, you look at the practice of hundreds of physicians in a big system, there'll be most of them will be in the middle. Some will be not too good physicians. Some will be really good physicians. So you have a kind of a distribution curve, but that's not helpful because what you really want to do is move the whole curve, not just to address the people at either end. So you can do this with AI actually, and I think people are looking at it. So AI driven clinical decision support, which we call CDS, the quality of care becomes dependent on not the individual clinician's fatigue or whether they remember things or whether they're distracted. AI helps them to maintain a standard level of care by reminding them, by recommending things to allow them to reach across systems without them having to type it in so that they can find information that affects their recommendations. So this level of consistency with the AI, I think, is what really makes the C-level folks very happy because if you can raise the mass distribution of practice excellence up, then you suddenly have a very powerful competitive advantage and much better care for the patient
Mhm,
as well.
mhm.
So I think it's a variance issue, but that means that you also have to, and I wrote an article about this on LinkedIn, when you have AI being so much part of the physician workflow that they're like an invisible assistant, one of the dangers is that physicians rely on them too much.
Yeah.
So they stop thinking. In fact, this is true in many industries. People are worried that we're going to get dumber with
Mhm.
AI. We just check the box. And that's not the right thing. Right? You have to be able to take the advantage of where the physicians excel. And that's when they are treating the tough cases, the edge cases where even AI cannot solve. But then it leads to other problems, like the physician will burn out from all that cognitive load. Every patient
Right.
is difficult, no
Mhm.
rest for the weary. So it's a lot of implications that I don't think a lot of healthcare leaders have really fully thought about, and I'm sure we'll consider them in the future, near future.
Yeah. Now, we often hear about digital transformation, but
Mhm.
what does digital maturity actually look like for a multi billion-dollar healthcare organization?
Yeah, it's interesting. When I talk to folks at different healthcare systems, many of them, in fact, most of them have probably already bought several AI tools. And in
Mhm,
fact, if they use Salesforce, it'll be Salesforce is bringing AI. If they use Workday, is coming in. Oracle, SAP, whatever. Every system is introducing AI and AI agents.
mhm,
So maturity is a transition from experimenting with separate, different AI agents to agentic orchestration. So, agentic orchestration is sort of a unified AI governance layer that manages a fleet of AI agents. So, it's not just one here, one there. You really have to manage the fleet because you may have agents doing things in one app or another app that maybe doesn't align with what you want to do.
mm,
And that is going to be chaos. There's a lot of technical debt, in terms of trying to figure out what these agents are doing, what algorithms are they using, Are they doing something that aligns with our strategy, our ethical guidelines? Are they biased? Are they not? If you don't have a viewpoint in visibility into all these agents doing their things, then really it's a very high risk for healthcare organizations. One agent might be sending PHI out of the system. Another agent might be really not following best practices, things like that. So governance, unified governance is important. Maturity means that the data isn't just stored, also it's liquid. So it moves securely between systems because the focus is on the patient journey, not really individual departments. So maturity means orchestration, but it also means looking at things from a broader point of view across silos. And that requires a bit of work on the part of the health system, the
Mm.
leadership. What do they want their system to do? What do they want to give the patient, what kind of experience, and so on and so forth.
Yeah, so in the back end, you have make sure the data mapping is good so that the experience for the patient is good based on the data mapping behind the
Mhm.
scenes. Okay. And also it looks like when you say orchestration, I
Mhm.
feel like is like the project manager, right? The
Yeah,
overseer, like it needs to know who is doing what and where and making sure that
yeah,
everything goes through smoothly
yeah.
for the patient.
For example, you could have let's say, a clinical department case manager, let's say, and they have a tool. Let's say they bought an software app that has an AI agent. So the first step in their journey of upskilling is to go from doing things themselves to learning how to utilize the agent to do it for them, right? So that's the first step. The second step beyond that is a big step, which is how do you learn to, as an organization, manage all these agents, so that they all work together. Let's say the nursing manager, the care manager, their AI agent learned something important. Well, then it should be shared with every other department. That doesn't necessarily happen, especially if you're using different tools. So the question is, how do you orchestrate actually different agents from different apps? And that's a really interesting question because there are tools that detect what agents are doing so that you can detect rogue activity, unsafe, risky activity. But I think my impression is still a very early field and the detection is only through sort of formalized channels, so there's no sort of general monitoring just to see what's going on.
Yeah. Just like having a Slack channel for each.
Yeah. Tell me what you're doing. And now agents are talking to each other like in their own language, I've read. So
Yeah.
how do you really understand what's going on? It's just a very interesting time in healthcare.
Yeah, I can imagine. So, how should VPs of technology balance the need for rapid AI
Mhm.
adoption with the rigid requirement of HIPAA and patient data privacy?
Right. I think HIPAA and the requirements, those are sort of hard guidelines. You can't really do it without, you can't go beyond. First of all, it's illegal. So that's the
Mhm.
first thing. But the second thing is it's not a good idea because that exposes you to a lot of risk. So security first, privacy first to reduce the risk. And then you really have to think about how do you comply with HIPAA and GDPR and all the other guidelines that are coming in, all the laws that will be coming in, like the EU AI Act and things like that. How do you comply with that in a situation where the technology is changing so fast? And I think that's a real issue because the EU AI Act was I think, the first major national law against, for privacy and cybersecurity. And it passed its first enforcement deadline and they couldn't enforce it because the technology, I think, had changed. So,
Or-
if you say, oh, this technology is risky, and then next month the technology improves to the point where it's not risky, well, then you have to go consider that again, review it again. So I don't think human teams can actually keep up because the
Mhm.
technology is changing on a pace that is far outpacing human ability. So I think ultimately we will have AIs monitoring AIs.
Yeah.
So I think that's the only solution I can see, because that's the only way to really, in near real time, find out what's going on and change, and find out the current situation quickly. Some organizations like ours, for instance, we have High Trust R2, which is a gold standard, R2 certification end to end for our platform. But there are many other certifications and not everybody does that. Some people just do self attestation, but that's like saying, I'm good and you should believe me. It's not as convincing.
Yeah.
But I think the benefit though, I mean, what's driving everybody in healthcare is the benefits are obvious. They're so huge. Every physician has tried out ChatGPT and Gemini and whatever. And they love it. They love being able to find, just like the patients. I got to see my doctor the other day and I used Gemini and it was right on. The doctor said, good job. That's what I think too.
Well, yeah, you go to the doctor to verify, like, you trust but you
Yeah.
verify type thing. So you go to an expert and you're like, "Is
Yeah.
this right?" You know?
Well, you have your set of data that the doctor doesn't know. The doctor has their set of data that only they know, like the lab tests
Right.
and stuff. So somehow you have to bring that together, and you can actually ask ChatGPT to do that for you. Yeah, it's an interesting time.
It is. So what is the most common mistake you see in healthcare leaders make when attempting to scale a pilot program
Mm.
into an enterprise-wide solution?
I think we are seeing a lot of pilots, and pilots are great, but I consider them kind of like a learning curve
Mhm.
because it's not just to prove that technology works, it's also for the health systems to understand how to use it, because it's so new. So after they do the pilot, okay, it works technically. The next step is actually how to scale it. And to scale it, you need a lot more than just the resources you use for a pilot. You
Mhm.
need governance, like we mentioned. You need probably a center of excellence that can manage it. You need to manage the pipeline of the inevitable hundreds of requests that will come in. You have to have some kind of business value framework figured out so that you can have some rationale for telling people these are the things we are going to work on. These things will be not as important. They'll be down the queue a little bit and so on and so forth. And then you need to be, and because of a center of excellence, and a lot of health systems have an additional group now called an AI group, a chief AI officer, and things like that. And sometimes they're combined with the automation center. And what they do is they have to oversee version control, security patches, and also model drift because over time, models drift, LLM models. So, and especially as you see these proprietary LLMs being developed by health systems based on their own information, and situations change over time. So you kind of, hope and pray that these algorithms still work, so you should catch it early before it goes to 30% inaccuracy or shows bias. And to do that, again, you need to have some data science expertise, I think, to figure out when an algorithm is going off base, some way to catch it and correct it. So I think eventually, for all these problems, going from pilot to production is a very different process. But if you don't do it properly, strategically, I think you just keep accumulating technical debt. So essentially, at some point, you're going to have to fix it. It's going to
Yeah.
cost a lot. But the longer you wait, the longer it's going to cost. Yeah.
That's like a slow leak, basically, like a
Yeah. Yeah.
plumbing issue, like a slow leak at home, and you're like, "Yeah, it's okay," like, "We'll patch it up with some tape right now." Or, at first we'll patch it up with some gum and then some tape over it, and then slowly it'll just, like, quit leaking, and then then you got mold, and then you're like, "The whole house is moldy," and now you gotta
Well, that's a
call.
funny thing. I mean, when you look at health systems, they're no better. If you think of all the legacy systems they have, hospitals. I was just reading some survey. It was like the typical hospital can have hundreds of legacy systems. And
Mhm.
can you imagine trying to connect all of those to the network or to each other? I mean, that's a lot of work, so you got to maintain that, maybe systems that the vendors don't even exist anymore, things like that.
Right.
I remember where I used to work, we would have, hematologists buying specialty software that would run under their desk in their office, and they would have to connect to the network. And then the IT folks would go, wait, what app is this? So anyways, it's just, like I say, accumulating debt, that you got to pay sometime.
Yeah, and it gets expensive because now with a rogue app that's been installed 25 years ago,
Yeah.
how who is patching that?
All those guys are retired.
Right, and also, like, what's the password?
Right, right.
What's the password? Who has the password? How do you change the password? And also, like, the programmers, I think it was what is it? Cobalt? Was
Oh,
it
COBOL. Yeah, COBOL. Yeah, there's MUMPS. MUMPS is another language. It was a foundation for Epic and Cerner and other electronic health records, but very old and a problem because today we would never design a program like that where you're binding the data to the software, software code. That's what it did. So,
Ooh.
but it works, so it's, yeah,
And so do you see most of those programs into, like, rural, um healthcare systems more so?
yeah, yeah. I think what happens is that, once it's installed and working, there's often the perception of a lot of risk in changing it or updating it and a lot of costs too.
Mhm.
So health systems don't usually do that until they have to. So, for instance, if there's a number of regulations that force healthcare systems to use the HL7 Fire endpoint, API, as a federal mandate going forward, and that's happened already. And the old system, nobody's maintaining, nobody knows how to do that with the old system. Then they may just have to figure out how to migrate to a new system that they have to pay the bill for, pay it for. And so that is going to be a one-time charge of migrating data, and then hopefully after that, that system will be good for another 20 years, But I think it's always painful because most hospitals have very little budget for IT, very little, and they're already on a very thin profit margin. So
Mhm.
it's a big struggle.
Yeah, I can
Mm.
imagine. So now in terms of competitive advantage, how can
Mm.
healthcare providers leverage data to not just improve outcomes, but to fundamentally change their business model?
Yeah, I think that right now healthcare, the business model basically is volume. The more patients you treat, the more reimbursements you get, so on and so forth. I think one of the big aspects of transformation, which is what everybody's talking about, digital transformation,
Mhm.
is moving from volume to value. And that's it's actually consistent with what the rest of the healthcare industry is doing. We're not having things like value based care, which is we're not paying for activity, we're paying for the outcomes of what you're doing. If you don't have good outcomes, we're not paying you or we're paying you less, right? So the value based thing has had a struggle trying to be adopted, but it's now becoming very much more prominent because we have data now. We can actually say, oh, your outcomes are better than the guy down the street, things like that. So you can leverage process discovery, deep analytics, and you can identify things like high risk populations. You can use AI to identify other factors that predict different risks and stuff. So essentially, the healthcare provider can take on more risk, more capitation, because value based reimbursement, for instance, because they have the AI tools to manage that risk profitably. They have
Mm,
AI tools that can predict, can and manage risk, can analyze things that nobody knew were coming, things like that. So instead of becoming a sort of place you go when you're sick, when you have a problem, you start being a health manager, and I think that's a different, much better position to be in. So you
mhm,
have a population of patients, and you actually become their health and wellness partner. And for a value-based system, that is actually very, very reasonable and good thing to do because the less they cost the system, the better. Better
right.
value, better health for them, less cost for the payer. Better reimbursements because you have a better track record for quality. And
Mm,
so everything is win-win. But again, that requires sharing data, which has
yeah.
traditionally not been true in healthcare. It means complying with federal mandates for sharing data. It means being transparent. It means transparent with your pricing, your quality numbers. And I think that's where the government really wants to go. And I think
Mhm.
it's good for the consumer, but it's going to be tough for the healthcare providers and the plans.
Yeah, it seems like it's going towards the preventative health
Yeah.
versus the reactive. And also, like, I feel like this type of healthcare would be better
Hmm.
for the patients because they're now be less scared to go to the hospital or
Hmm.
to go get checked out if they
Hmm.
felt some kind of way, right? Like if they
Yeah.
start to feel sick, they know that is based on value
Hmm.
versus volume, right?
Hmm.
So the
Hmm.
value that their health is important to the physicians versus, just come in, I'll give you a script and I'll be paid type thing. So yeah, I think that would be like we
There's
don't
a
want to be numbers,
yeah,
right? Like we don't want to be
yeah,
just we wanna
yeah.
be a person.
I mean, in the old days, that was the most profitable thing to do. They essentially it was more profitable to have you sick because
Mhm,
the more go in, the more the money the hospitals, healthcare providers make. But now with value based care, it's not true. But the problem is the major problem has never been the intent of the healthcare provider. I think good physicians have always counseled wellness, preventive health. The problem is the patient. And so, in other words, most people, especially if you're in middle age or young, they don't pay a lot of attention to their health. Really, they only pay attention when they get older. So, at the age where it's really important to do preventive health and exercise and diet and everything else, for many reasons, people don't comply, they don't listen, they change jobs, whatever. I think the Academy of Family Medicine did a study. There's at least like 60 or 70 different factors that can cause somebody to be not compliant with what the physician recommends.
mm,
And the interesting thing is that they also found out that about 80% of your health status is not based on what the physician is trying to do, what the kind of care you get. It's actually based on non medical things. where you
Okay.
live, your income, your social network. If you have a network, if you, for instance, Kaiser, when I was there, we would sometimes recommend people go to get good food at a local grocery store, cook it themselves, things like that. But we had an area in the Bay Area, it was very poor. All they had was fast food. So that
Yeah.
advice is irrelevant. So,
Yeah, you can't do it.
it's not reality. So Kaiser actually started a program to deliver fresh food for a nominal price to their patients. Now that's creative thinking, right? But that in the long term, much better for the patient, much better for Kaiser
Mhm.
because they're not going to cost as much. They're going to be healthier. They're going to have lower blood pressure, et cetera, et cetera. So I think it's that kind of thinking. You're not just helping people when they fall ill, but you're actually helping them stay healthy. I think that's a shift, and actually, I think actually there's a competitive advantage. Yeah.
Okay. Okay. Now, how do you manage the human element, getting the
Mm.
buy-in from skeptical clinical staff when introducing disruptive technology?
Well,
Like, like the AI scribe. Let's say that I am scared of AI, right?
mhm.
Like I'm an individual that is scared of AI. How do you convince me about
Yeah. So, well, with AI, not so much. I mean, I think there's so much coverage of AI that most physicians will see the benefit of it. There's always going to be a few, that will be like the Luddites. So
it?
we hate all technology that's going to
Uh-huh.
take over the world, and there's some truth in that. But most physicians will love it, and because they see the benefit, because it directly benefits their practice. They don't have to take notes. They don't have to turn to a computer and search for data. They can just ask, and the AI might tell them that kind of thing. So that direct benefit is very useful. But the way that, for instance, my company it's a AI automation platform in the cloud, started with the back office, with the back office paperwork. The filling out the forms of medical claims, appeals. Physicians spend on the average about half their time on paperwork.
Mhm.
And nurses even more, about half the time on paperwork on their shift, when they're in the hospital. So that time is just wasted time. It's just manual. You type in stuff, you fill in, you sign things. So automation has been able to address that. That's taking away the stuff the soul crushing paperwork, the stuff that makes you burn out it's just waste of time. So now the stated goal is to help people practice what they call at the top of their license. That is, as they are trained, the worth of a physician is not filling out paperwork. The value of a physician, very highly paid, not in filling out paper, neither a nurse, who's also very expensive. They should not be filling paper. They should actually do what they're paid to do, right? Which is what they're supposed to be doing. And so practicing at the top of your license means you're doing things that only physicians can do or only nurses can do.
Okay.
So the problem with that is it's good, right? It's good. But I had the thought that let's say if AI can handle the administrative burden, which is great, but now suppose they bring it into the clinical practice to handle the mundane clinical cases.
Mm.
So maybe instead of physician doing it, they'll hand it to a nurse. The nurse will use AI, take care of things like the AI could diagnose, like sore throat, urine infection, diarrhea, things like that, asthma, whatever, allergies. So what happens to the physician? So the physician, when they go into the office in the morning, their whole schedule is full of people who cannot be solved by AI. If you think
Right.
about it, that's pretty scary. That means
Mhm.
even with AI, they'll be seeing these patients because they need to be diagnosed and nobody knows what's going on. They don't fit any pattern. They'll need different kinds of tests that you don't know. So that's going to cause burnout of a different kind, which is cognitive burnout.
Okay.
So the physician will have a migraine headache when they go home. Basically, instead of tiredness, they'll have a headache. So we have to think about that because when we engineer AI and get people to adopt it, we really have to think about the human side of it. That is, we still want humans to be involved, right? So
Mhm.
that's another question. But if we want the humans to be involved, we have to design it for the advantages and the limitations of human beings. I think that's actually the next step in designing AI to work better, to be adopted better.
So now what is the CFO's argument for investing in preventative
Mhm.
health tech today versus traditional reactive care models?
I think one of the things that CFOs have to deal with is unexpected, anticipated stresses.
Sure.
CFOs do well when they can predict revenue, predict demand, they can predict reimbursement. And then along came COVID. Everything went
Yeah.
everything went into the toilet. So
Yeah.
everything's unexpected. You can't even get the drugs from China, things like that. and you have to pay extra to get drugs from elsewhere, that kind of thing. So CFOs, I'm sure, had an ulcer during those times. So, what is the goal for a CFO? The goal is operational predictability, and that's where the AI comes in because right now the traditional model for healthcare is reactive, right? The CFO just reacts. Oh, you know what? There's going to be a strike next month, and we better hire more people, contract people. It's going to cost more, and whatever. So these
Uh-huh.
unexpected disruptions cause headaches, so basically unintended. So the typical reaction to that is reactive. The CFO, oh, there's going to be a strike. We're going to have to react and hire more people to keep the care going. So it's interesting because during COVID, they had to actually do something different, which is use telemedicine. And now
Yeah.
telemedicine is a mainstream mode, right?
Uh-huh.
But the reason they usually that reactivity works better than proactivity in the past is because healthcare doesn't change that much. So now healthcare is changing very fast, even to the point of different roles for physicians, nurses, pharmacists, techs, and so on. So when things are changing that fast, it's like with the security thing is only AI is going to be able to predict how to manage and how to smooth the cost curve, how to
Uh,
smooth, how to maintain and even allow you to be creative some way to make up in revenue what you're going to lose in other areas. So I think it's the smoothing the curve, the operational predictability, and essentially it's an insurance policy against all the factors that are happening, the rising cost of healthcare, the shortage of labor and everything else. It's not
uh,
easy, I mean, even AI has its limits, but you could be creative with AI. You can ask the AI, what do people in similar situations across the country do? That's something that would be very hard for you to do, and it could, in a couple of seconds, tell you, and you could look at it and go, hey, this is pretty creative what they're doing over there. Let's try that. So there's a lot of power in it, but I think for the CFO, probably one of the main things will be how do you do more risk management and predictability?
yeah. I mean, I would say they should put a fund on the side for like ransomware, and something like
Yeah,
that on the side,
yeah,
maybe some funds, a small
hmm,
percentage, some like a saving account,
yeah,
right?
yeah.
Like a savings account on the side, like just in case we get a ransom note somewhere,
It's like
ransomware.
insurance, like insurance.
Yeah. Yeah, self-insured, right? Just in
Mhm.
case, like, and also make sure that, we do preventative cybersecurity, right?
Yeah. Have you heard about Mythos? The latest.
Yeah,
Oh
mhm.
boy, if you had
That's a
something
whole
like
nother
that,
episode.
well, you better use something like Mythos to just check all your vulnerability points in your system, so you
Yeah,
can make sure that nobody can penetrate and stuff. But yeah, it's the interesting thing about healthcare breaches as opposed to other industries is there's a time element to it. So
mhm.
patients that need surgery like tomorrow, you cannot wait, and pay the ransom in a week. It's too late. So it's the urgency that makes the hackers love it. Because the hospital has really little choice. So
Yeah, life was on the line, right?
yeah,
Many lives are on the line. The
yeah,
NICU, all the babies are in the
yeah,
NICU. They're waiting on, a
yeah,
system to come back on just
yeah,
to stay alive. That's
yeah,
tough.
yeah. But it's kind of scary. I mean, hackers are not ethical. They don't care about that. They just know that
Yeah.
there's a huge pressure on hospitals to pay up. And I guess and I don't know if there's ways to create redundancies that could be brought up, redundant systems to address that breach. I think it's an interesting idea, maybe mirroring a system.
Yeah, there is,
Hmm,
and I would say that it might be costly. That's
hmm.
one thing, right? Like mirroring systems and stuff. There's also backups, but then that's a whole other episode. There's a lot of stuff that we can do,
Hmm.
but yeah, it's just like um, it's also costs,
Yeah,
right? So just imagine the amount of data that a hospital has
right.
duplicating that, and then the systems duplicating that also, and
Hmm,
just,
hmm.
making sure that is redundant and all that stuff. But I'm quite sure that it's possible. It's not a impossible venture.
Yeah,
I think the cost would be a lot. So we would
yeah.
have to have a CFO argument.
I guess they weigh the risk of a breach and the cost of a ransom versus the cost of putting something in that may never be needed, that kind of thing.
Right.
And
Yeah.
it's always the issue. But yeah,
It's just the getting insurance, like getting a car insurance, right?
yeah,
Like you're a safe driver and you're driving and whatnot, but then you get into an accident because somebody else has
yeah, yeah,
reared you in a back, and you're like, you
yeah.
believe you're safe, you know. So if you were advising a CISO in the
Mhm.
healthcare space today, what would you say is the most overlooked vulnerability in the digital supply chain?
I mean, obviously, there's a lot of benefits for AI in the digital supply chain, but I think the vulnerability is, as I kind of referred to before, is embodied in the question. You have 50 different AI agents working in supply chain. Do you know what they're doing? That's the
Mhm.
first question. Second question is, are they stepping on each other's digital toes? Are they all doing the right thing? So it's a governance of orchestration, it's a governance of logic. What are they doing actually? And I think that's not an easy one because that's the intersection of what you want to do, what the software vendor has provided that allows them to do certain things and not do other things. The fact that the coding of governance and ethics into AI is still very early, but it's a very interesting area. So that kind of thing, I think it would make CISOs very nervous. Like, okay, I'm gonna get fired. Something's gonna
Yeah.
happen. I'm gonna get fired. So I think it's you either clamp down really hard, like the EU, for instance, the EU AI Act, clamp down really hard, or you allow innovation to happen, right? So it's always a balance. If you clamp down too hard, nothing's going to happen. In fact,
Mhm.
people, software companies are leaving Europe because they can't operate in that environment. They can't do anything. But you come to the US, it's like it's the wild, wild west.
Yeah. There needs to be a big in between.
Yeah, something in between that makes sense, for the level of risk. It involves patients, is probably a higher barrier, that kind of thing. But so it's going to be zero trust, not just for users, but for the AI models themselves. I think
Mhm.
that's a new area. I heard from somebody at a conference that I was at recently saying that people are they're trying to experiment with hard coding ethical and legal and moral guidelines into AI algorithms, which I don't know how they can do that. But it'd be interesting. It'd be interesting if you could do that. Let's say it's a certified AI algorithm that has been tested somehow. And then I read articles about AI algorithms that have gone rogue, and deceived their users that they're not doing what they're doing. I mean,
Mhm.
deception, so AI agents. So then I don't know where the truth is, I mean, so
Yeah. We live in a wild, wild world.
yes. I hope in 5 years you'll figure out, like, okay, this is what we can do, but it's so early. It's exciting, and I'm kind of in the middle of it, which is really great because I'm just started as a physician. Now I'm kind of a technologist kind of person.
Mhm.
But there's a lot of people in healthcare that are wondering what's going to happen because it's not just making things more efficient. It's also changing the roles of healthcare people. And I think that's the part where people have to be really careful. For physicians and nurses, most nurses would love spending more time with patients, less time on paperwork. That's for sure. And
Yeah.
then leaving work on time, that kind of thing. And being able to hand off their patients to the next shift by having AI produce the list of
Reports.
tasks and things like that, save time so they can go home, save an hour, so they can go home and be with kids. But I think it's the next step beyond it is a little bit scarier. And let's say AI is able to make up part of the gap in the labor force shortage. What should the people that are still in healthcare be doing? What's the value we have for society? When AI can do a lot of the thinking and automation can do a lot of the activity. And I think it's a deeper question. And I think part of it is what do the consumers, what will they accept? Do they want to have a robot doctor? A lot of them are consulting on Gemini and ChatGPT, so
Already.
essentially they're already doing that.
Mhm.
You trust a robot doctor more than you trust a human doctor, who may forget things and stuff? Or do you need that human to human trust, that's so important in healthcare?
Yeah. And
Yeah.
also, like in healthcare, certain roles like radiologists or even the lab technicians, that would be different for them when
Mhm.
AI is interjected because what they would do would be different, right?
Mhm.
There would be more
Mhm.
so overseeing the AI
Mhm.
bots at that
Mhm.
point, being the human in the loop, as they
Mhm.
say, versus,
Yeah.
you know.
Recently, I gave a talk on AI governance at one of the student classes at Berkeley, UC Berkeley, on
Mhm.
AI governance. And a lot of these people, a lot of these folks, students are like pre-med and bioengineering, folks like that. And there's a lot of good questions about what is the role of the healthcare worker, right, in the future if it's not knowledge, right? If it's not knowledge retrieval, if it's not insights into treatment, what actually is the role? And I think that's a really good question. We don't know what the answer is, but a lot of it is a different skill set. Like you were saying, instead of in the future doing things themselves, they have to manage an org chart of agents that's doing it for them. That's a managerial skill, right? You have to
Right.
keep those agents happy and make sure they don't get sick, make sure they their family time, things like that. So that's a different skill. And so we're not teaching that, of course, in medical school yet.
Uh-huh.
That might be the near future for a lot of folks. Like, how do you
Yeah.
manage different AI algorithms from different companies, right? That's a huge issue. A
Yeah.
lot of people are not waiting, already using ChatGPT. Doctors are using ChatGPT to treat patients, which is kind of weird, scary. You're uploading public data, I mean, in PHI into a public, into a public, which is going to train on that data. So,
Yeah. That's
so
scary. I don't think
yeah.
that's HIPAA compliant.
Yeah. Well, you type fast enough, maybe nobody will get it. Nobody will detect it. Yeah, no, it's a lot of questions, and so people are creating, LLMs with walled gardens, things like that. So, and that's understandable, but then you don't necessarily have the advantages of the larger public LLM. I mean, the way to do it, you could use a one way access, things like that. But I think if you find a case, for instance, a patient case that is very different than what you have in your little proprietary LLM, you're going to be in trouble, right?
Mm.
At some point, you have to deliver that PHI to the wider world so you can ask for help. Right? And so you could do that by masking the electronic health record number,
Yeah.
the details. You can do things like say, what if we had a patient like this? What would you do?
Right. Like age. If the patient is female, 42, with 3 kids, that has, this is this weight, this height, and,
Yeah.
history of blah, 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 and maternal grandparent is this and that, and then,
Hmm.
you know,
Yeah.
more vague, more anonymous.
Yeah, actually, yeah, there's some people that believe that you can never totally de-identify, a patient. It's some way there's always a way to identify them, especially if you say, oh, they live in this town. There's not that many people in that town with a certain constellation of symptoms. And maybe you need to tell the town because maybe the town is next to a toxic dump or something that
Mm.
you want to check out. So it's very hard to totally anonymize it. But it's interesting because I have talked in the past with several startups that deal with synthetic data, which is totally, made up data. So it's not any PHI. And they can model a real world population with synthetic data. So, and it can be a one-way model. So you cannot even get back to the training data. So then you have this one-way model. And then you can ask the one-way model, like, okay, if you either this patient, if you have enough people in that model, essentially anonymous digital twins, if you have enough people in that model, you could actually probably get some good answers, like what could this patient have? But again, it's based on how you train it. And I think in the foreseeable future, the cases that are difficult for the patients have that are very unusual diseases, things like that, there's actually, because it's unusual, there's not much training data. So AIs will not be very good at it. So that's where
Mhm.
the physician really steps in, right? They've been trained on these cases in medical school, even though they're rare, but that's why that's how they earn the money. That's
Yeah.
basically it. They have the expertise to recognize the zebras, not the horses, but the zebras.
Uh-huh.
And that's where you provide a lot more value. But I think, will we ever get to the point where an AI could do that? Maybe, if you walk in the exam room, not just a microphone, but you have a webcam
Uh-huh.
and maybe you have a odor cam, something that detects odor and measures posture, then you could kind of get what a physician gets over a whole career of practice. That is, you get a lot more input than just text, like most LLMs get. You get, how did the patient behave? How fast did they move? How slow? Did they have a depressed, low voice? Did they, compared to past? You can do things where maybe it's kind of like it becomes a gut feel kind of thing
Mhm.
that you can mimic what a physician feels because he knows a patient for a long time and walks in the room and say, "Oh, well, what's happening, Mr. Smith? You seem depressed, whatever."
Yeah.
So that kind of stuff, I don't know if we'll ever get there. It'd be scary if we did because
Yeah, you're just putting the ethos here.
yes, it's very discouraging. But no, I think it's encouraging too. I mean, basically, there are a lot of areas where we thought AI would never penetrate for 30 years, 40 years, and now it's gone beyond that.
Yeah.
It's
Yeah.
crazy. Yeah.
It would be a little scary at first to have a AI robot doctor come to
Mhm.
me and be like, "So I haven't seen you in a while, but you don't look good." Like, you look depressed. Like, okay. That's kinda scary. The thought of it is a little scary. Yeah.
Yeah. But I'm experimenting right now, with Claude and with other kinds of things where I'm doing vibe coding, with low code, no code,
Mhm.
just putting a prompt to build an app. And it's strange. After a while, you start treating the person like a person. It's like, thank you for doing
Yeah.
that. You did all this work. I really appreciate it. To them, it doesn't matter. They're programmed to be nice, right? So, oh, you did great work, But actually, if they're a programmer, you should do that. But if they're an AI, they don't really care. They're not keeping tabs on, are you being polite to me, right? So
Are you sure?
maybe adopting their tone to my tone, right? Maybe if I'm just abrupt and businesslike, they will be like that. I'm not sure.
I don't know. We could test it out. I mean, like, I'm
Yeah.
always nice to my Gemini. I'm like, "Please and thank you. Can you please?" I think it's also, like, it's a way for me to practice.
Yeah.
Also, when I write emails,
Hmm.
I wanna make sure that I'm polite or,
Right.
at least
Right.
nice. So, I and I'm like, "Give me 5 sentences of this, this, this," it's more like, "Can you please give me 5 sentences that would make sense to based on this video?"
Yeah.
Something
I mean,
like.
I was trained to say please and thank you,
Yeah, exactly.
as most people are, But so I tried one time, like it didn't do what I wanted to do. So and then I typed in "you failed," so it didn't seem to react. I was like, okay, let's try this, let's try that. But there's no emotional sorry, No,
Well, I have the sorries. I
you
get the
do.
sorry.
Okay,
Yeah, I
yeah.
get the sorry. I was like, "Oh, that didn't work out. Like, that's not something that I wanted." And then like,
Mm,
"Oh, I'm sorry. Let's
hmm.
try this, blah, 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 blah." I'm like, "Okay."
Well, I put in one idea once in this vibe coding thing, and it came back with this thing like, "This is a brilliant idea. This could be the next unicorn," and all. It went on and on. And said, "Wow, it must be really good. Good idea."
Yeah, it's really nice to us, like,
Yeah.
really, really nice. So now, moving on, where do you see the intersection of AI and personalized medicine in the
Mhm.
next 24 months? And what should the CEOs be doing today to prepare?
Yeah. I think it's a story of data. That's basically what it is.
Mm,
And so in the old days, when you said personalized medicine, you almost always meant genomics, right? Like if you have a certain genetic structure, makeup, then you'll be more prone to this disease or that disease or whatever it is. So that's what we meant by personalized medicine. Today, with all the factors that affect healthcare and your medical status, like I mentioned, 80% of them are outside medicine. The data that makes up that personalized care pathway is even more important that it be accurate and reliable.
mm,
And so, if you want to give a personalized care pathway, which is always the best for a patient, the best for their condition, the best treatment, the most efficient treatment, and so on and so forth, and you have data coming in from everywhere, like they're wearing a Fitbit, there's cameras in the room, or there's a way you can get information on their shopping habits, or their medical condition. If you have all that data together, I think if you want to create the best personalized care pathway, you have to make sure, first of all, that that the data has integrity, which means it's reliable, accurate. The source is rated. This metadata that shows how reliable the source is that you think, how reliable. And then you have to create something that is going to take advantage of all that data across all those silos and sources of information. And that will give you a personalized engine for taking the best care of that patient. And so competitively, the CEO that wins will be the CEO that organizes the data architecture first. And it's interesting because there's a corollary to that. That is, if you have so much information about a patient, the habits, do they smoke, do they diet, exercise, whatever, you have monitor AI on the edge, right? So it's AI everywhere telling you about what they're doing, and they've opted in. You can give them better care, but you're probably kind of removing them from the insurance pool, right?
Yeah.
Insurance pool is dependent on no data. That is, you don't know who's going to get sick. So everybody pays in hoping that, you'll be the one who benefits if you get sick. The problem with that is, of course, people who don't take care of themselves are going to get sick. And so why should the people that are healthy pay for those guys? Increasingly, even today, I think when you apply for health insurance, there's a differential rate, like if you smoke or if you have a family history of diabetes or something. So it's a little bit of a differential rate. But in the future, there'll be so much information known about you that maybe people will be able to price your insurance much more accurately.
Yeah.
And so let's say if the hospital can know that, oh, you're going to cost them a lot more money. What does that mean? Does it mean that they will try to discourage you and make you go to some other hospital? I think that's really interesting, but it's kind of all these things that people haven't really thought about, but there are real implications. I mean, if you're a hospital with a tiny margin, profit margin, you're going to figure out, oh, you know what? you know, 30% of our care is with people who cost us more than we can make through reimbursement. What should we do? Should we keep them because it's for community benefit and we're a nonprofit and that's a good thing to do? Should we try to be creative and create other ways to take care of them that are not as expensive, et cetera, et cetera? So brings up a lot of questions when you actually can analyze so much data.
Mhm.
Yeah.
Yeah, it becomes a different problem.
Yeah.
Yeah. Now I have two more questions for you, a little bit more personal on the personal side. With such a high stakes career, what is your personal operating system for maintaining mental clarity and making difficult strategic decisions?
Well, I think it's hard, because the landscape is changing almost every day.
Mhm.
So the question is, what are the principles that don't change? I think
Right.
that's actually the question. In the midst of change, what are things you can hang on to that would, sort of guide you? And
Mhm.
so for healthcare, and I'm sort of not in healthcare anymore. I don't practice medicine. I used to be a doctor, and I'm still a doctor, but I don't practice. So in healthcare, you think about what's not going to change, right? Healthcare is always going to be patient centered. So anything you do for the patient, centered around the patient, is going to be important. Healthcare is always going to be about data, and data is growing exponentially. So if you do things around data, like cybersecurity, like what you guys are doing, and around AI governance, algorithms, bias and hallucinations, AI algorithm certification, and things like that, that's always going to be really important. Automation is another principle, so the principles about that. But you think about those things that don't change, and you kind of go and you kind of navigate your way through that and go, okay, where do I want to be? What role do I want to take? What's going to be meaningful within that changing framework? I think that's what really a lot of young people are struggling with. So
Mm.
I'm not struggling so much myself because I'm kind of on the other end of the career. So
Yeah.
I've kind of done my thing, and I've gone through a lot of change. Like I said, a lot of technology change the last 30, 40 years, but I'm not so concerned. I'm just having fun looking at where we're going. But for a lot of
Mhm.
these young people, it is still an open question. And people actually ask me like, okay, if I become a physician, how long will that last? What I thought I was getting into, how long will that last? And that's a good question. You know,
Yeah. Now, for you yourself, like during that time, what kept you grounded?
oh, probably my parents.
Mhm.
Used to be a doctor. It's an Asian thing, you know. But for the longest time, even though the internet was coming and everything, the whole thing about being a doctor was to practice, practice, practice the way you were taught for 30, 40 years. And then, like I like to tell people, you retire and then you go play golf. Nowadays you go play pickleball, something like that. But it was not a lot of change. I mean, people thought, medicine does, people are always going to need doctors. That's what people used to say, right? Always going to
Mhm.
need doctors. And it's still true, but maybe in a different way, So you don't have to worry so much about, oh, what career should I choose is this and that because it's going to be pretty stable. And the justification for that was human anatomy doesn't change, right? So not for a long time. Human anatomy will
Right.
never change. So there's some basic principles there that is going to sustain the career. But nobody realized that the data is growing so fast to the point where we have to create machines to handle it
Mhm.
and to understand it. And then when we do that, it's kind of out of our hands. All of a sudden, it's not so much doctor autonomy anymore. When you practice with AI, your hospital leader is going to ask you, "How come you didn't follow the recommendation in this case?" And then they got sicker. You know,
Mm.
it's very hard
Yeah.
for you to justify that. So, in a sense, it's like what I said at the beginning. We're all getting dumber. We're getting dumber, but not in a good way. One of the things I think that people who look at this carefully should always do is always test the doctor's expertise. Like, for instance, AI should never recommend, like, this is a diagnosis that this patient has. You should always recommend it with a probability of success. And then
Mhm.
it should give 2 or 3 or 4 other diagnoses that could have lower probabilities of success. In other words, you're trying to get the doctor to use their brain, to actually think, well, maybe I thought it was this, but and it normally would have checked the box. But guess what? There's another thing down here in number 3 that I didn't really think about. Maybe this could be because I still feel in my gut of guts, in my gut feel that
Right.
something's wrong with this patient that I don't
Yeah.
understand. And
Yeah.
so I think AI can be used in that way, but you got to be really careful in how you use it because it's just too easy to let it do all the decision making.
Mhm. Yeah,
Yeah.
because you can go in with the same
Mhm.
symptoms of a cold,
Mhm.
allergy symptoms, COVID, and, mold. They
Yeah.
all
Yeah.
have similar symptoms, and you
Exactly.
go in there, you're like, "Which one do you have?" Like, "I don't know."
I mean maybe someday, as a consumer, there'll be so many things monitoring you at home, remote monitoring sensors, things that you could just automatically enter all of that, even if you didn't know how important it was, just enter all of it into ChatGPT or Gemini or something. And then it might come up with a better answer. And like I said, maybe you have a better answer than the doctor who doesn't have access to all those things. So
Mhm.
except they have more experience. So I think it's interesting because one of the other issues for patients is this information asymmetry, where they don't know medicine, right? So they don't even know what to ask. They don't know what they don't know. And so they read on the web and they think that's what they have. And that's, it's just not a good way to do medical stuff. So the information asymmetry, if you have a really smart medical AI that can tell you, no, this is not important, like the same thing a doctor would do, right? It's probably not this because it's so uncommon and you didn't go to this country, you didn't pick that up. So that's much better than just asking Google, it's like, what do I have with these symptoms, because
Right.
that's generic. Then maybe you can address some of that information asymmetry so that when the patient comes in, like nowadays, you bring them the printout from
FNT.
ChatGPT. It's better. It's actually better to discuss that, because you're more prepared,
Mhm.
you're better able to discuss with doctor, and as long as the doctor is able to handle it, I think
Yeah.
that's really good way to go. Yeah.
Yeah, I usually go to my doctors with a few, ideas of what I think I have, and they're like, "No, that's not it." I'm like, "Oh."
Tell me why.
Yeah, tell me more. Tell me more, I wanna know. "Oh, this is why," and blah, 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 and I'm like, "Oh, okay, okay." At the end of the day, I got my doubts answered, right? It's just
Yeah.
either it was confirmed or not, so it's all
Yeah.
good.
Yeah.
Like, for me, I usually go in a little bit more informed.
Uh,
I don't know if they like it or not,
yeah.
but I go in there, I'm like, "Okay, well, this has been happening, this why, and blah, 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 and whatnot," and I've gotten worse, I
Mhm.
think, or better. I'm not sure, I'm not sure. I've got more detailed, right? I got more detailed.
Yeah, yeah.
Yeah.
I think I
Uh,
read a survey that how people pick their doctor today is different than how they used to. They used to ask their friends, right, and who would
mhm.
recommend people. Nowadays, a big factor is how tech savvy their doctor is.
Hmm,
And
okay.
so maybe it's more in the young people, but apparently that's a big factor that if the doctor doesn't even know how to use the internet, forget them,
Yeah.
that kind of thing.
Yeah,
But I thought
I
it's
had a
interesting.
I had a cardiologist that was his data keeping, his record keeping was all on paper.
Oh, wow.
Yeah, and that was 3 years ago.
Mm.
So I was like, "Okay, that's interesting." Like,
I hope he
I got
didn't.
referred by my PCP, and I'm like, "Okay, sure, I'll go there."
Careful with that coffee, don't spill any of that.
Yeah, exactly.
But I
Yeah.
think I mean, in another 10 years, there'll be no paper records that are gonna be kept, it's all electronic, and then it brings up other issues, like safeguarding that data and stuff like that, or correcting that data if it's wrong, things like that, but at least it's accessible.
Yeah, and
Yeah,
duplicates,
yeah,
duplicates, wrong name, like, wrong spelling of the name.
yeah, yeah.
Right? But it's the same person, that's one
Mm,
thing. Then the birthday might be wrong, but it's the same person.
mhm.
Social security number might be different, but it's the same person. Like those
Yeah,
kinda
yeah,
issues there. So how do you consolidate? How do you figure that out, right? Like, it's
yeah,
another
yeah.
again, another problem. There's
All kinds
so
of
much.
problems.
Yeah, it was just like, problem here, problem there, problem, problem, problem. But it's all good. That's why we're here. We're here to
Yeah,
solve
yeah,
problems.
yeah. Like I said, it's an interesting time in healthcare, and I'm looking forward to things that will happen. I'm sure people, very smart people, much smarter than me, are going to figure out how to handle AI and how to establish guardrails and how to make sure algorithms are good. But I think it's that part of it is going to take some time because the technology is always way ahead of the legal, the regulatory, the ethics. It always is.
Yeah.
It took the FDA, years to figure out what to do with healthcare software, and a mobile app.
Mm.
They finally came up with something that was good. I mean, that it was just passing data through. You don't have to regulate it like a medical device and things like that. But it took years.
Yeah. Yeah, it's just like, when the internet came on and there was crime that was committed via internet,
Yeah.
and they did not know, like, legally, they did not know how to deal with that,
Yeah.
right? So, it took years to get legislation through.
Mhm.
Legislation alone takes a long time.
Yeah.
So,
Yeah.
it has to pass so many desks, right? So,
Which
can
means
we
our legislators have to know AI, right? Like how fast it's changing, and to pass laws that are generic enough to be, good for a while, and so
even if it was good for a year, and then the
mm,
next year do a
yeah,
revision, right? Like a
yeah, yeah.
addendum or something, like, have the basic of it for a
Mhm.
year, and then the following year we can do a an addendum add to it.
Yeah.
So it would be like AI law
Mhm.
1.2, or 2.0, because that's the thing is that it goes by so fast,
Mhm.
as you said. So,
Yeah,
like, how do you keep the laws at that pace? Like,
yeah,
back in the day, processors would change every 18 months, right?
yeah,
So
yeah,
now processors is what, 6 months maybe? I don't know.
yeah,
I'm not following that, but, like, if as you said earlier, if AI changes every week, like, how do you keep up the laws to
yeah,
that?
yeah. It's almost like, what they should do with these laws, they should do an experiment with their vibe coding the law. So,
Oh, wow.
and then so every 3 months you tell the AI, "Can you go out there, survey the landscape, see what new technologies and rewrite this law, rewrite it so that we're good for another 3 months," and
Uh-huh.
that kind of stuff, and then, of course, the delay is gonna be the human part, human review, and how does this affect our constituents and this and that. That's always gonna be slower. You wouldn't trust that to the AI. You can
No.
ask the AI, "Oh, it's gonna, make sure this it's unbiased." Well, you don't know what the AI is doing.
Yeah, exactly. But the idea of having a base law, even
Hmm,
if we take the EU law, the EU
mhm.
AI laws, right, the act, and then modify it to
Yeah,
be
yeah.
the American one, the
Mhm.
US one, and then from there have that baseline.
Yeah, yeah,
Then, do a revision of it every 3 months.
yeah,
Have a team to do that, like, and then also have AI help.
yeah, yeah.
I don't know. I don't know. I'm just spitting out ideas.
But basically what it is opportunities everywhere.
Mhm. Yeah.
If you're gonna do a startup, there's a lot of ground that you could cover.
Yeah, definitely. So for the last question,
Mm,
what is one book or piece of media outside of medicine and tech that
huh.
has profoundly shaped how you view leadership?
Well, that's interesting. There's one book that I found very useful. I've read a number of books, not so much nowadays. And besides the Bible, which I read and stuff, there's a book called The Five Faces of Genius.
Okay.
And it's by a woman who did some research. It's really interesting because way back, when you look at some of the thought leaders, Harvard Medical School, Harvard Business School, and so on, where is the value created in a company? The value is actually created by just a few departments. One of them is the marketing department. One of them is the product department. Of course, they create value, right? So that's invention, that's innovation. So she went around to figure out through history, how did the people we acknowledge as geniuses, what kind of approach did they take to make them a genius and to achieve what they did?
Mm.
And it's really interesting. She found out like there's 5 different models. So, for instance, one of them is the person who plagiarizes, takes something and makes it better.
Yeah.
And then there's a guy who finds mistakes, a product that didn't work and then somehow repurpose it and came up with a whole nother use for it. I think that one of the examples she mentioned was like the Post-it note as a classic example. Some researcher somewhere was trying to develop glue and kept failing because the glue didn't stay, it didn't stick. And finally he decided, maybe there's a purpose for this. I can put it on paper, right? I can stick it to things like a Post-it note and take it off, right? Stick it on. So that was an invention of the Post-it notes, which have sold billions. So
Yeah.
things like that, So there's 5 different models, and I think it's interesting when you really look at a company, a healthcare system, who's really adding value versus who's just working a job and going home. Who's really creatively adding value, changing healthcare, providing the kind of experience that patients want. It's not a lot of people. There might be instances here and there, but I think we need to put more priority on that piece of it. So when I was at Kaiser, I did innovation and stuff, but very few healthcare systems do that. They might have
Mhm.
a separate little group do that, but it's unusual. Yeah,
Yeah. We were trained to be worker bees,
yeah. No
basically.
risk, right? Do the
Yeah,
same
no
thing every time.
no risk. We were trained to be worker bees and not have that creativity
Yeah.
in that. It's like, yeah, you'll have an art class here and there and things outside the box, but uh, other than that, or
You
like
know,
during your,
in healthcare,
projects.
in healthcare, we look at all the doctor specialties. They don't pay you to be creative. So
Exactly.
you cannot go on your own unless you don't mind being sued. So I even asked a friend of mine who's a plastic surgeon, I said, are you creative? Do you get to be like doing art on people, like real art? And he says, no, actually, it's very restricted. People have their idea of what they want.
Mhm.
And it's you don't get to, it's very rare that you get this, they come in and say, you do whatever you want, create whatever you want. I trust you, No, it doesn't happen that way. So
No.
in medicine, it's not creativity that's rewarded. On the other hand, in the business of medicine, we have been stuck in the same model for years. And
Mhm.
so and now with new technology, I think there's a lot of new areas of potential: remote monitoring, telemedicine, virtual care, digital care, avatars, digital twins. There's a lot of technology that can change healthcare, but it's gone in this way for so long that it's going to take another bit of time before it really changes.
Yeah. It's like government,
Yeah.
right? The government just has been the same for a long time. And
Yeah.
then when somebody comes in to disrupt it, you're like, what? Like
Yeah.
got somebody different, you're like, they're doing
Yeah.
something different.
Yeah.
And you're
You
like,
don't change unless you have to, like COVID, then you have to change. But otherwise, it's really, people don't like to change.
yeah, that's true. Change is hard,
Change is hard. Yeah.
but it's fun, I would
Yeah.
say.
Yeah.
Personally, I have experience. Change is fun.
Yeah.
It's hard, but it's fun. So, Dr. Chow, it has been a pleasure
Oh, it's been,
speaking with you.
yeah.
It has been a very
Likewise.
good conversation. I've learned a lot. So I hope we do this again.
Yeah. I'll give you an update in 5 years if I'm still around.
Yeah, if the podcast is still around. I hope so. But yeah.
Yeah.
So I thank you, and I thank you to the Wise crew for watching, and I see you guys next time.
Yeah.
Bye.
Thank you. Thank you for
Thank-
having me.
Of course.
Cool.